Hello dear students, today we are going to learn a clinical vignette on multiple sclerosis. A 28-year-old female presents to the neurology clinic complaining of blurry vision in her right eye that has progressively worsened over the last 4 days. She notes that moving her right eye is painful, describing an aching sensation behind the globe. Upon further questioning, she recalls an episode 8 months ago where her left leg felt heavy, numb, and tingly, and it lasted for about 3 weeks before spontaneous recovery. She attributed that prior episode to a pinched nerve from running. On physical examination, visual acuity is 20 by 20 in left eye, 20 by 100 in right eye. Color vision is notably diminished in right eye, and when a light is swung from the left eye to the right eye, both pupils paradoxically dilate. A relative afferent pupillary defect was there. And fundoscopic examination of the right eye reveals a normal appearing optic disc, and neurological examination reveals hyperreflexia 3 plus at the left patella and ankle, with a positive Babinski sign on the left. So we have a 28-year-old woman presenting with progressively worsened blurry vision in her right eye for 4 days. The first important clue is her age and sex. Because multiple sclerosis commonly present in young adult females, her visual loss is unilateral, subacute, and associated with pain during eye movements. This combination is highly characteristic of optic neuritis. So she is a young female with optic neuritis, and the pain is usually described as ache behind the eye and occurs because movements of the globe stretches the inflamed optic nerve sheath. She also reports the episode 8 months earlier when her left leg became heavy, numb, and tingly, and which recovers spontaneously. And this history is extremely important because it suggests a previous neurological episode involving a different part of the central nervous system. So, a past history of a neurological symptom is also there, which is not related to the current presentation, which is optic neuritis. So, her symptoms are distributed in time and space. The spontaneous improvement is typical of demyelinating relapse, followed by partial or complete remyelination and neurological recovery. Now, on examination, visual acuity is reduced, which is 20 by 100 in right eye, and it is normal in the left eye. Color vision is disproportionately impaired in the right eye, and this loss of color saturation, particularly the red desaturation, occurs in multiple sclerosis and it is known as dyschromatopsia. It is the very sensitive clue to detect the optic nerve dysfunction. Next clue is the Marcus gun pupil. Marcus gun pupil is the demonstration of the relative afferent pupillary defect. When a light is moved from the normal left eye to the affected right eye, both pupils appear to dilate because the diseased right optic nerve transmits a weaker afferent signal to the midbrain, and that's why the pupillary constriction, which was initially present because we were moving from the left eye to the right eye, it appears falsely as if it is undergoing dilatation. Despite significant visual symptoms, fundoscopy shows normal disc. This tells us that the inflammation is occurring behind the globe and producing the retrobulbar optic neuritis. So the classic phrase is the patient sees nothing and doctor sees nothing, because patient has problem in the eye and doctor has clear eye examination. And finally, hyperreflexia and a positive Babinski sign in the left leg indicate a upper motor neuron or corticospinal tract lesion. Therefore, this patient has evidence of involvement of more than one anatomical location, the right optic nerve and the motor pathways supplying the left leg. Now come to the next slide, which is the MRI of the patient. This sagittal MRI image demonstrates multiple hyperintense lesions around the corpus callosum and lateral ventricle. If we can see these finger-like projections arising from the base, from the ventricle, and they are touching the ventricle. So these finger-like projections are known as Dawson fingers, and uh, these fingers represent the areas of demyelination which appears hyperintense on T2 weighted or FLAIR MRI sequences. These demyelination sequences occurs along the deep medullary veins, so it follows the tract along the deep medullary veins. It can also occur, so this is the periventricular location. It can also occur in the juxtacortical location. It can also occur infratentorial location, and it can also occur in the spinal cord. Now come to the MCQs. The patient's current visual presentation and pupillary finding are most consistent with which of the following diagnosis? Option A, anti-ischemic optic neuropathy. Anti-ischemic optic neuropathy usually occurs in older patients with vascular risk factors and commonly produces sudden painless visual loss, not the painful visual loss, with optic disc swelling. Option B, retrobulbar optic neuritis. Yes, it is correct. It is the common presentation of multiple sclerosis. Option C, angle closure glaucoma. Angle closure glaucoma presents with the red eye with sudden severe pain in the eye, and on tonometry you can find the increased intraoptic pressure, increased intraocular pressure, and on gonioscopy you can find the angle closure glaucoma. Option D, papilledema is the optic disc swelling caused by the raised intracranial pressure, and it is generally bilateral, and visual acuity may remain relatively preserved during the initial presentation. So it is less likely. And option E, central retinal artery occlusion. It produces sudden severe painless monoocular vision loss and classically shows the retinal whitening with cherry red spots. So therefore the clinical clues strongly supports the retrobulbar optic neuritis, which is common initial manifestation of multiple sclerosis. Now come to the next MCQ. The ovoid hyperintense lesions seen on this patient's MRI are classically oriented perpendicular to the lateral ventricles. What is the anatomical basis for this specific pattern of distribution? Option A, deposition of beta amyloid in the penetrating cortical arterioles. Beta amyloid causes the cerebral amyloid angiopathy or CAA or Alzheimer's disease. So it is not seen in this case. Option B, demyelination occurring along the course of deep medullary veins. As I have previously discussed, that the demyelination occurs along the deep medullary veins which are running vertically perpendicular to the ventricles, and the process of demyelination occurs along these these veins, medullary veins. So you will find the patches of demyelination occurs along these venules, and these appears as Dawson fingers on MRI. So option B is correct option. Option C, ischemic necrosis in the watershed zones between major arterial territories. Watershed ischemia occurs at the borders between major arterial territories and produce a different anatomical distribution. So this is not the correct option. Option D, accumulation of tau proteins in the ependymal lining. Tau accumulation is associated with the neurodegenerative disorders. Option D, centrifugal spread of slow virus infection from the choroid plexus. No, it is not the correct option. Now come to the next MCQ. If a lumbar puncture were performed, which of the following cerebrospinal fluid findings would most strongly support the underlying diagnosis? Option A, elevated opening pressure with more than 1000 polymorphonuclear cells per cubic millimeter. This is seen in cases of infection like meningitis or encephalitis. So this is not the correct option. Option B, markedly elevated proteins with normal cell count, which is known as albuminocytological dissociation. Albuminocytological dissociation is classically associated with the Guillain-Barré syndrome. So it is not the correct option. Option C, presence of 14-3-3 protein, and it is seen in cases of prion disease, not in cases of multiple sclerosis. So it is also not correct option. Presence of option D is the presence of oligoclonal IgG bands that are absent in the serum. Yes, it is true, because the pathology or pathogenesis of multiple sclerosis includes the activation of naive T cell, then that T cell activate the B cells, and those B cells produce the immunoglobulins that attacks the oligodendrocytes and causes the autoimmune inflammation, which causes the degeneration of or demyelination of the central nervous system neurons, and this demyelination after healing causes the plaque formation. So the option D is correct option. Option E, decreased glucose and elevated lymphocytes. This is seen in cases of tuberculosis, fungal meningitis, or some other chronic infections, and not in cases of multiple sclerosis. Now come to the next MCQ. The patient's history of left leg numbness 8 months ago combined with her current vision loss satisfies which core diagnostic requirement for this disease? Let's see the options. Option A, dissemination in time and space. Yes, it is correct option, because dissemination in time means that neurological lesions or clinical events have occurred at different points of time, and in this patient the left leg sensory and motor symptoms occur 8 months ago, whereas optic neuritis occurring now. Dissemination in space means that different anatomical regions of central nervous system are involved. The current episode involves the right optic nerve, while the previous episode and upper motor neuron lesion and upper motor neuron findings suggest involvement of a spinal cord or corticospinal pathways. So, according to the McDonald's criteria, dissemination in space and dissemination in time are the two most important characteristics of multiple sclerosis. Option B, Uthoff's phenomenon. Uthoff's phenomenon refers to the transient worsening of pre-existing multiple sclerosis symptoms when body temperature rises, such as during exercise, fever, or a hot bath. So it is not the diagnostic of multiple sclerosis, but it occurs in cases of multiple sclerosis. Option C, Lermite sign. Lermite sign is an electric shock sensation traveling down the spine when a patient flex his neck or her neck, and it occurs in cases of multiple sclerosis. So this also occurs in multiple sclerosis, but it is also not the diagnostic criteria for it. Option D, Charcot's neurological triad. Actually, the current McDonald's criteria have evolved from the initial Charcot's neurological triad, and that triad was consist of intentional tremor, scanning speech, and nystagmus. So this is not the current diagnostic criteria for the MS. Option E, clinically isolated syndrome. Clinically isolated syndrome is a single typical demyelinating episode that does not yet fulfill the complete diagnostic criteria of the multiple sclerosis. So this patient has experienced more than one characteristic neurological episodes involving different regions. And so the core concept is dissemination in both time and space. And this is the McDonald's criteria. And you have also to rule out or exclude the alternative diagnosis to complete the McDonald's criteria. Now come to the next MCQ. What is the most appropriate immediate treatment for the patient's acute flare of vision loss? So the patient in this clinical vignette is experiencing an acute and significant demyelinating relapse which causing substantial visual impairment. In such cases, high dose corticosteroids is the mainstay of treatment, and it reduces the inflammation, restore the blood-brain barrier integrity, and it also accelerates the neurological recovery. And a commonly used regimen for this is the intravenous methylprednisolone, and it often given in the high doses such as 500 to 1000 milligram daily for at least 3 to 5 days. So the correct option will be the option B, high dose intravenous methylprednisolone. Important point to remember is that the corticosteroid generally accelerates the recovery from acute relapses, and but they are not useful to control the long-term disease because the other better disease modifying therapies are available for the treatment of multiple sclerosis. So use of steroids is only indicated for the acute relapse cases. So what are the disease modifying therapies for multiple sclerosis? These are divided into the based on the efficacy. Highly efficacious drugs include the anti CD20 monoclonal antibodies like ocrelizumab, ofatumumab, ublituximab, and rituximab. Another highly effective drug is alemtuzumab, It is the monoclonal antibody against the CD52. It is also highly efficacious drug. Other highly efficacious drug is mitoxantrone, which is an anthracycline chemotherapy, and less efficacious or moderately efficacious drugs are interferon beta, glatiramar acetate, dimethyl fumarate, and S1P receptor modulators like fingolimod, ozanimod, and ponesimod. So these are the disease modifying therapies for multiple sclerosis. Let's see the other options also. Option A is tissue plasminogen activator. It is not the treatment for the multiple sclerosis. It is used in the management of acute ischemic strokes. Subcutaneous interferon beta 1A and option D oral glatiramar acetate. These both drugs are the moderately efficacious drug for the multiple sclerosis. Option E, IVIG or intravenous immunoglobulin, is used in the form of pulse therapy, and it is used to reduce the annual exacerbation, and it is not used uh, for the acute relapses. Now, what are the take-home messages? Multiple sclerosis commonly present in a young female with neurological deficits which are separated by time and separated by the space in the CNS. Optic neuritis presents with the unilateral vision loss, with the pain with eye movement, and presence of relative afferent pupillary defect, which is known as Marcus gun pupil, and normal fundoscopic examination. So the disease is located behind the eye in the retrobulbar area, causing the demyelination and painful optic neuritis. MRI markers include the periventricular plaques radiating outwards from the ventricle, known as Dawson fingers. CSF shows the oligoclonal IgG bands and indicate the intrathecal antibody synthesis, and you will not find the presence of and this IgG band in the serum. So it is not coming from the blood, it is directly present, it is directly synthesizing in the brain. Treatment include the use of IV steroids for acute flares, disease modifying therapies like ocrelizumab, rituximab, alemtuzumab, mitoxantrone, etc. to prevent the disease progression. So this is all for today. Thank you.